Morning, evening.
Share the video. Our last year video. Hi.
Hello.
How are you? Am I audible? Inspiration. You can't hear me?
Oh,
Fine.
you come on and off, on and off, on and off.
Oh, really? Okay. Maybe. How is it now?
I can hear you now.
Oh, very good. You're always beautiful with this gorgeous color, girl. I love you. It's my favorite color.
Oh, purple, huh? Okay.
I love it. And our logo is purple. Pink to purple.
Okay.
Happy to see you again. We are waiting for Dr. Edson to join. We will start class on time. Yeah, Dr. Edson is getting ready to come.
Great. Good. He's wonderful.
Thank you so much for joining us and supporting our class despite of your busiest schedule. Thank you so much. Appreciate it, Gail.
No problem. I'm good. I'm good for a couple of hours this morning.
Thank you so much.
Oh, my morning, your night. But how is everybody?
Everything is fine.
How is everybody doing over there here in Belize? And like I'm in Belize right now. I'm going to Canada in a couple of weeks, but here the COVID, they're saying no masks, and we haven't had any new cases in the whole country.
Oh, lovely. Such a lovely news. Very nice. Good for you. You're enjoying.
I am.
I came back to India in last 3 days from Iran. Iran, we are wearing mask, and it was mask restriction. And now in India, it is mask restriction. I hope one day we reach to without mask life.
But you have more people. You have way more people here. Our country is very small.
Yes, that's right. That's right. Yes. But it was very good managed in Iran. Our cases reduced. I hope in India the same happen and we reach to your situation. Yes, it is a huge country in India. It is a huge population. Of course, it's not easy to manage, but anyhow, it's manageable. Very good.
Good.
Yeah, we are going to have a good celebration for 8th of March. I like you all guys to come join us. Bring your guys and make it very beautiful, fantastic celebration. All women from different parts of the globe. Stay together and enjoy that day. Hi, Dr. Edson. Welcome. Thank you so much for being on time. We are waiting for you. Thank you so much. All attendees are joining. Anna Brown, Juliet, Sediqe, Zahra, Maral, Raziye, and our training committee, Mrs. Gail Johnson, and today trainer committee from our OB committee, Dr. Edson joined us. Very good. I guess everybody are joining. Thank you so much. Thank you for joining on time. We are going to start our class on time. We are from Lilly Excellence Center, a multinational organization headquartered in London, the UK. Our expertise lies in OB/GYN midwifery services of global standard. We offer OB/GYN, family health, and midwifery services to clients from various countries. Offer training and certification to aspiring midwives, healthcare professionals, and caregivers. Conduct workshops to generate awareness on the benefit of natural birth and midwifery, family health, SRHR, support women empowerment, and work tirelessly in all related fields to achieve our ultimate goal, the betterment and progress of womankind. Here in these workshops, there is a chance to interact with the pioneers in the industry, listen to their experiences, and get an insight into the challenges, success stories, progress, and opportunities that are unique to this line of work. You can participate and share your own experiences if you wish, or simply sit back and get an understanding of how we work. You can ask questions, inquire about certification, and if you find yourself thus inclined, or simply spend your time gaining knowledge about a field that's gaining momentum across the globe. You can reach us at the following further details in email info@LilyMCenter, and our Facebook Lily E Center, Twitter Lily E Center, and Instagram the same. We have YouTube channel Lily Excellence Center, and our website is www.lilymcenter.com. I am Leila Mustafi. I am founder of Lily Excellence Center, and I'm proud to be with this fantastic expert committee, training committee, Mrs. Gail Johnson, and our obstetric trainer, Dr. Edson. Please, if you don't mind, let's know from where you are joining, from which country you are joining. Please write in chat box from which country you are joining to this class. This is third class of Advanced Midwifery with Dr. Edson. And if you have any question, please write in chat box. We will try to answer to all of your questions at the end of the class. If you let me, first, I want Mrs. Gill to honor us and have a few words to inspiring all your attendees, and then we will go to Dr. Edson to start the class. Yes, Gail, please, we want to hear welcoming words from your beautiful words. Thank you.
Well, what the best news I've had for a long time is one of the young ladies that I've been teaching here, and she's been coming to some of my births here in Belize, and she has just finished her midwifery school, and I am just so jealous because she's got 60 years of all the joy that I've had. And I told her, I said, I'm so jealous. You have nothing but joy and love coming your way for this next 60 years of your life. So yesterday I was with her and we were hugging and being very happy. And I think it's amazing for all you young women that are learning more and more about being a professional, but using old tricks of the trade, and that you will get to share your knowledge and love with so many women and see so many miracles. Every baby is a miracle. Can you imagine one cell deciding who's going to be a piece of a fingernail, who's going to be an eyebrow, what part of that one cell that is within women's bodies is going to make a miraculous, unique person that may change the world. Every birth you attend, that baby may change the world. It definitely will help make it a better place. So, ladies and gentlemen, all of you that love babies and women and change, we create it and see it, the miracle happen every day. So, all of you young people, I'm jealous of you all.
Always, you are inspiring us, and I'm really honored to have you, Gail, as one of our committee. Thank you so much. I check our chat box that where you guys are joining us. Yes, very good. This is Gail from Belize and live in Canada. Zahra is from Iran. Dr. Edson, welcome everybody. I'm pleased to be with you. Thank you so much, Dr. Edson. So everybody, if you are ready, we can start our class with Dr. Edson, and please keep writing in chat box from where you are joining us. And if you have any question, write in chat box. We will answer your question at the end of the class. Our class will be 45 minutes and 5 minutes for Q&A session. Please stay with us and let's hear from you. Welcome, Dr. Edson. First of all, we want to have a small description from your fantastic profile, and please let's start. Thank you so much. Over to you, Dr. Edson, please.
Okay, I'm very pleased to be you again. I'm talking from Brazil, and now we have always beautiful sunny days, and we have a beautiful sunny and warm day here now. And yes, good morning or good afternoon for you all. And can I begin? Hello, Gail.
Hello, how are you?
Hello. Let me share my screen. Okay, do we have a full screen here?
Yes, doctor. Yes, doctor.
Yeah. Okay. Well, I think we can begin. Okay. Well, then I will begin. This is our second meeting, or is it the third? No, it's the second. Yes.
Okay, this third one, doctor.
Yes. Yes, it's the second time I will talk to you, and I'm very pleased to do that. And we will continue the lesson or the lecture we've begun the last meeting. And I will still be talking about the second stage of labor. And today I will talk about pushing, posture or position during second stage of labor, and techniques for perineal protection. Then I will talk about these three topics. The first one is about position in the second stage of labor. I find very curious. I was reading a paper, and the author of this paper stated that position for giving birth meant a conflict between monitoring efficiency and comfort. I cannot see this kind of conflict. The woman can choose the best position for her, and this will be at the same time good for monitoring, efficient for monitoring, secure, safe, and comfortable for the woman, even if she chooses the best position for her, the most comfortable position. If you want to study a little more about birthing positions in labor, I can suggest you to know this very important paper. It was published by Atwood more than 40 years ago, and it was he firstly described or classified the many possible positions during labor. And according to Atwood, we had at least three classes of position: supine position, neutral position, and upright position with gravity involved. I will not deepen in the Atwood classification, but here is the reference. If you want, you can download it and you can read it and to understand a little more. But if you want to study even more, this is a seminal work of Engelman. It was published more than 100 years ago, And it's impressive that everything we know today, Engelmann had already said for more than 100 years ago. And this author studied the birthing positions all over the world, mainly in primitive people. And it's a wonderful book. You can read it. It's a wonderful book. And one of the conclusions, the main conclusion of Engelmann, was that in ordinary labor cases, the expulsion of the child should be expected in an inclined position. And there are many ways to have an inclined position: kneeling, squatting, semi-recumbent, in bed, on the chair or lap. And this is the way the great majority of uncivilized people do it, and for the following reasons. First, these positions permit the free use of abdominal muscles. The force of gravity does not counteract the expulsive effort as in the recumbent position, nor does it unite with it too freely and hasten labor unduly, as in the erect posture. Then, this is the second reason. And the third, with the assistance of a rope, a stake, or other support, the parturient can vary the inclination of the body and correct the labor, hasten or retard it, the descent of the child, relieve the pain, changing the axis of the body, and throwing the fetal head toward the sacrum or symphysis. And injury to the soft part is less liable to occur in these positions. I think it's really impressive. Today we have many radiological tests that have been proving that. Then we have been proving one thing that was already known many years ago, and that was used by many uncivilized people many years ago. Then it's a very curious book, a very interesting book. If you want to know a little more, read it. I like it very much. It has many figures and many histories of many people. And here, this is a very interesting picture, because this means what was labor made in the 20th century. You can imagine that these people here, these doctors here, are preparing for a big surgery or a neurological surgery, orthopedical surgery. No, this is not an orthopedical surgery. These three people here are preparing to receive a baby. This is a laboring woman. This is the kind of thing people made of childbirth, a surgery, and as a surgery, this should have this kind of characteristics. This is drawn from a movie. It's a very interesting movie too. It was made in 1940, and it describes the work in Chicago Maternity Center in this period. The name of the movie is The Fight for Life. You can find it too, and you can see it. It's a very historical and very important movie if you can know the evolution of obstetrics in the 20th century. Well, and finally, we arrived in the final or in the beginning of this the current century, and we have found finally that the free to let woman to be free to choose the best position or posture. This is the best way to assist childbirth. Then we have moved from this kind of posture that has a very strong history of violence. This picture was drawn in Brazil, in a Brazilian maternity center, and we can see that it has even dealt to fasten woman's leg And this is a history of violence. And we can move to another very different kind of assistance in labor. And here we have a set of pictures that I love these pictures because you can see here the partner of the woman, and here you can see the woman, if she wants, she will shout, and there is no problem about that if she wants. And the partner is has the hand of the woman in a very strong way. You can see they are looking one to another. And as soon as the babe is born, you can see even the partner is kissing the woman. And they are very, very strongly tied one to another. And the woman is free to choose the best position for her. The maternal positions in second stage of labor has a long history that dates 2 or 3 centuries ago. Morisot was a French obstetrician, he's a very famous obstetrician. And from the 17th century, they have already discussed something about maternal position in second stage of labor. And at that time, they stated or they believed that the best position was an inclined position. The best must be such that when the woman is ready for delivery, she must be lying down with the body well accommodated, that is, head and chest a little high, so that she's neither lying or sitting. That way she breathes better. For this, she must move away her legs, bend her legs to the buttocks. In addition, she's allowed to hold the hands of some people. This is very interesting. It's very important to hold the hands of some people, as this will make her feel better during contractions. You can see this is it's not. This is published. It was published in 1668, many years ago. But what does the evidence about the position in the second stage, in the second period, really say or really state? And I like this picture too. It was a multiple pregnancy. This was, I believe, the second one, and both of them were born inside water. Well, we have 2 Cochrane reviews. The first one states something about maternal position in the second stage of labor without epidural anesthesia. Hello. And for this review, there were 30 randomized controlled trials. More than 9,000 women contributed to the analysis. And comparisons included any upright position, birth or squat stool, birth cushion, and birth chair versus supine positions. And what were the conclusions? The conclusions were that the possible benefits for upright posture are a very small reduction in the duration of second stage of labor, mainly from the primi-gravid group. The reduction, the time of reduction, it's not really large, but it's a very small. But maybe this is not the most important thing, the duration of the second stage of labor. The most important thing is the comfort for the woman. If the woman feels more comfortable, then this is better. And there was too a reduction in episiotomy rates and assisted deliveries. The only problem, we have to know it, that there was an increased risk of blood loss greater than 500 milliliters. And there may be an increased risk of second-degree tears, though we cannot be certain of this. Then these were the conclusions about maternal position in the second stage of labor in women that don't receive an epidural anesthesia. And we have the other one when women received epidural anesthesia, there were the number of women was not so great, but there was eight trials, more than 4,000 women, and again, upright positions were compared to recumbent positions in this update. And 5 of these trials were conducted in the UK, 1 in France, and 2 in Spain. And the conclusions were that recumbent positions may reduce the need for operative birth and C-section without increasing instrumental delivery. And mothers may be more satisfied with their experience of childbirth by adopting a recumbent position. And the studies in this review looked at left or right, lateral, and semi-recumbent position. But in 5 years ago, they published a new study. The BUMPS study was published in the UK. There were more than 41 maternity hospitals in the UK and 3,000 randomized women. This was the largest trial ever made about this topic. And the women were nulliparous, cephalic, single, and were more than 37 weeks. There were no premature pregnancies, and all of them with epidural in situ. And women were free to change their position at any time, adhering to the planned position. Then they planned 2 positions, a group vertical position, and 80% of these women remained in the vertical position, and a reclined position, and 75% of the women remained in the planned reclined position. Well, what were the conclusions? Conclusions were the following. Reclined positions increased the chance of spontaneous vaginal delivery when compared to the vertical positions. And we can see here that the difference in the chance of spontaneous vaginal delivery in the reclined position, 41% compared to 35%. And yes, operative vaginal delivery were least frequent for reclined position as well as for C-section. And here we have the number needed to treat of 70. This means that for every 17 women that have or that are assisted in a reclined position, we can avoid 1 C-section. We don't really know why these differences were found in the study. Why would women with epidural in a reclined position be more likely to get spontaneous vaginal delivery? They have many hypotheses, but there was not really an explanation, a clear and right explanation for these findings. But this was a very important study, and when this study was published, there was a lot of confusion, at least in Brazil, because some people found that when they've seen the conclusions that a vertical position was not the best, some of them believe that this means horizontal position should be the best, but it's not this. This is not a conclusion. Conclusion is about reclining position. We are not talking about any kind of horizontal positions, and this is the conclusion. Well, the WHO 2018, I think everybody knows the intrapartum care for positive childbirth experience, the WHO recommendations. And here are the recommendations for birth position. For a woman without epidural, this woman should be encouraged to adopt a birth position of their choice, including upright positions. This is the recommendation. And for a woman who received an epidural, this woman should be encouraged the adoption of a birth position, including upright positions too, because we should give the woman the freedom to choose. These are the recommendations about position. Well, the next talk will be about pushing. But if you want to make a pause and to comment something or to make questions, this is the time, or we can let it for the end of the lecture too. What do you think? Can I follow? Well, I will continue. I will talk about pushing in the second stage of labor. You know, pushing is an effort, an involuntary effort, and it will increase intra-abdominal pressure, and it will increase the strength of uterine contractions too, because it adds some strength to uterine contractions. Then it's an involuntary urge to push, and it may precede complete dilation of the cervix, or sometimes it may occur even after the recognition of complete cervical dilation. Then it can happen this way. This variation in time of the initial urge to push is due to other obstetric factors that must be favorable for further fetal descent and birth. Well, there is one thing very important to pushing during second stage of labor, is the reflex that is known as a Ferguson reflex. It was described more than 50 years ago. And what is the Ferguson reflex? It's a feeling of unintended pushing of the parturient due to the descent of the fetal head to the ischial spine, compressing the pelvic cavity. When fetal, there is a microphone open, please. There's a microphone open. Hello. Well, the Ferguson reflex is a very important reflex for labor. And it gets more intense as delivery progresses, as the fetal head reaches pelvic floor. Then it's a totally reflex. It's involuntary. And neuroaxial analgesia may cause a lessening of the sensation of uterine contractions and descent of fetal head. And this can cause a prolongation of the pushing time and tiredness of the womb. And it can compromise or interfere with this kind of Ferguson reflex. Well, we have two, or at least two classifications for the pushing. One of them is the kind of pushing we call directed, coached, closed glottis, Volsova or purple pushing. And many doctors and midwives still seem to consider in their function to aid in a bit and even coerce the mother into forcing the fetus as fast as she can through her birth canal. Then often there is a chorus of coaches yelling, push, push, push. We have been doing this for many years. Why we have been doing this for many years? And this is a kind of thing, I think it's universal. In many places all over the world, we have been seeing this kind of practice to direct, to coach pushing, and many, many times. And if there are 1 people in the birthing room or 2 people, 3 people, for everybody coaches the woman to push, and everybody shouts to the woman to push. Well, we have 2 very important questions about push. The first one is if we should coach the woman indeed. And if we should coach the woman, how should we do that? Then we have two different kinds of pushing, spontaneous and direct or coaching or coached pushing. And the second question is when to begin pushing. We can do it early, and then this is called the early pushing, as soon as dilation is complete, or delayed pushing. Then in this kind of pushing, we will wait for fetal descent. Spontaneous versus or compared to directed pushing. Directed pushing is characterized as a Volsova pushing technique because the woman is instructed to take a deep breath at the beginning of the contraction, to hold her breath and push as long and hard as she can in synchrony with her contractions. Then this is called, as I already said, a directed, coached, closed glottis, because she has to close the glottis. And spontaneous pushing is completely different because this approach is self-directed and in hair bearing down techniques. Then there's the main characteristics of spontaneous pushing are, first, woman has an open glottis and vocalization or use of intermittent exhalation technique. This means that the woman can shout if she wants. She's not forbidden to shout, as somebody or some people believe. Some people believe that when the woman shouts, he or she loses her strength. This is not really. Second, pushing efforts are a response to an involuntary urge, as I've said, the Ferguson Reflex. And pushing starts from arresting respiratory volume without first taking a deep breath, because a woman always will have some air inside and it will breathe. And it typically pushes 3 to 5 minutes for 3 to 5 seconds, followed by a breath and release of air. Directed or coached pushing has a longer duration, sometimes 10 until 15 seconds. It's longer. And pushing efforts vary in intensity and frequency. They are more physiological pushing. The Volsova Maneuver, or the directed pushing, consists of a voluntary forced expiratory effort against a closed airway, closed mouth and nose. This can increase intrathoracic and intra-abdominal pressure and the corresponding changes in blood pressure. There are very complex changes in blood pressure, in hemodynamic situation, and there are complex transient cardiovascular and neurohormonal alterations. And although rare, this maneuver is not free of potential side effects, including chest pain, syncope, arrhythmia, or even cerebral stroke. This is even very rare, but they are already described. Then the Volsova Maneuver, or directed pushing, is not a kind of thing free of problems or free of adverse events. Well, spontaneous pushing as a definition, and I like this definition very strongly, and it was already described by another very important author that was Caldeiro Barcia from Uruguay in South America. And you can see in 1979, he he gave a very important lecture in Japan, and everything we have been talking about nowadays, he had already talked in 1999. And the number of pushing efforts in the interval between them at each uterine contraction, as well as the duration and the strength of each one, are regulated by the mother herself. The pregnant woman does not receive the usual instructions to make prolonged and intense efforts. They are not instructed to close the glottis during pushing efforts. Then I can see, these are the difference. Then we have to know them, and we have to know the difference of the outcomes. Because many people they coach the woman to push because they believe this will decrease second stage duration. We have to ask if this is true, if this is really true. And what said the evidence? This is not really true. We can hear, this is a review also by Cochrane, and they included for the duration of the second period, 6 trials, 667 women, and we can see here there was no difference in the duration of the second stage of labor when we compared spontaneous versus or directed pushing. Then if we direct or if we coach pushing because we believe this will decrease second stage duration, this is not true. This has no evidence, and this should be abandoned because this is the conclusion. And there were no difference for many other outcomes, including the condition or the ABGAR of the child after childbirth. And here I think we have a very beautiful picture too. And this is the same woman I've already shown to you, the woman that was kissed by her husband at the final of the child, of the birth. And here we can see the woman, she's shouting because some women feel strong, feel powerful when they shout. At least this is a kind of thing we can see here in Brazil in our culture. Women feel strong and shout sometimes is a sign of power. And here is the baby is born. But for women with neuroaxial analgesia or an epidural, when initiate pushing, because we have seen when the woman receives an epidural, then the Ferguson reflex may be a little blurred or sometimes abolished. And then this can modify the physiology of childbirth. Well, for a woman who received neuroaxial analgesia, delayed pushing sometimes is not some people believe to delay pushing is not good, but they have already studied this too, and they compared immediate versus delayed pushing, and the conclusion were that delayed pushing during the second stage of labor did not affect the mode of delivery, although it reduced the time of active pushing at the expense of a longer second stage. Then you can see this. No difference for the mode of delivery for operative vaginal delivery, C-section, delivery risk, but there was an overall duration of the second stage of labor. It was increased when you delay pushing in women who received an epidural. And the incidence of chordal amnionitis and low umbilical cord pH were also higher in the delayed pushing group. And this was the conclusion from this study. And as a consequence, here we have a recommendation from the ACOG, and they recommended that delayed pushing should not be performed in nulliparous patients with epidural for the intent to increase their chance of spontaneous vaginal delivery. And this is the recommendation made by ACOG in 2018. But there is another review that considered another very important outcome. The very important outcome was maternal postpartum fatigue score, because it was lower in the delayed pushing group. And this is very important. And this was not considered in the previous Cochrane or in the previous review. But this review, it was a Chinese review, and in this review, they included the maternal sensations about childbirth. And this is so important as second stage duration. And the conclusions was that delayed pushing can decrease the total pushing time and decrease the fatigue score after delivery without significant adverse events compared to the early pushing group. Therefore, they recommended that caregivers instruct the pushing time at the optimal moment, allowing women to have more resting time and save energy during labor. I think this is wonderful. We have not to decide or to have decisions based only in second stage duration. We have to consider also maternal feelings and maternal sensations, and this was included in this review. So here we have the WHO recommendations about pushing. The method of pushing. Women in the second stage of labor should be encouraged and supported to follow their own urge to push. Then we have not to coach or to direct or to order the woman to stop their breathing, because this is not physiological. And second, about the method of pushing, early or delayed. For women with epidural analgesia in the second stage of labor, delaying pushing for 1 to 2 hours after full dilation or until the woman regains the sensory urge to bear down is recommended in the context where resources are available for longer stay in second stage and perinatal hypoxia, and if perinatal hypoxia can be assessed and managed. Then even for women who received an epidural, we can respect her own sensations and her own urge to push. These are the recommendations. Well, and it's okay. And here I have the third topic for today, techniques for perineal protection. Well, I will talk about episiotomy and other policies for perineal protection. Episiotomy is put here in the top of perineal protection, but I have to let it very clear that episiotomy is not considering a technique for perineal protection anymore. It was considered so in the past, but it's not considered a technique for perineal protection anymore. But it was indeed, and I will tell you a little of this history. And this history began in the beginning of the last century. I think this is a very important publication. It was published in 1920 by LEC, and LEC was a physician and obstetrician in Chicago Maternity Hospital in this time. And he defended the episiotomy of a kind of a technique to protect perineum. And hear what he said. He was used to understand episiotomy as a technique to save the facial and muscular structures of the pelvic floor. And most of the damage resulting from labor. This is what he has written in that time. Most of the damage resulting from labor is due to injury, rupture, distraction, and displacement of the fascia, and leads to tearing of the muscles. We can take direct action to save the facial and muscular structures of the pelvic floor. And by incising the fascia at its most vulnerable point and reuniting it after delivery, we are almost always, not invariably, able to eliminate all damage to the pelvic floor. And primary union, and then to close it, is the rule. And examination later shows that virginal conditions are usually restored. I think this had a great influence all through 20th century and all over the world, because many people or everybody believed that this was true. And hear what he still said. Episiotomy was useful to save the baby from the killer vagina. This is comic or tragic. If a baby were to have its head caught in a door very lightly, but enough to cause cerebral hemorrhage, we would say that it is decidedly pathological. But when a baby's head is crushed against a tight pelvic floor and a hemorrhage in the brain kills it, we call this normal. You can see, should babies be born wearing helmets? Because I think it was what he was saying. Babies should be born wearing helmets because it was too dangerous to pass through vaginal canal in childbirth process. And they believed, and many people believe it until today, we have to intervene to save. So frequent are these bad effects that I have often wondered if nature did not deliberately intend women should be used up in the process of reproduction in a manner analogous to that of the salmon, which dies after spawning. Here, I think this is the basic of intervention in obstetrics that remained for more than a century. And here is the movie, The Fight for Life, because this movie describes the transition, the hospitalization of women in childbirth. It's a very curious movie. You can see it. But finally, we arrived in 1983, Tucker and Banta review. This is a cornerstone review for obstetrics, because for the first time, the authors of this review stated that indeed, there was no clearly defined evidence for the efficacy, particularly for routine use of episiotomy. In addition, although poorly studied, there was at that time evidence that postpartum pain and discomfort are accentuated after episiotomy and serious complications, including maternal death. Then this is a cornerstone publication, 1983, and because they reviewed more than a century, more than 100 years of publications about episiotomy. And they did found that what people believed was really true. And from that time, people began to make studies and to make some trials. And soon, and it was clear and was clear soon after that a routine or a liberal use of episiotomy was not recommended for women undergoing spontaneous vaginal birth. Because if they believed episiotomy was used to protect perineal, from severe trauma, this was not true. Indeed, episiotomy as a routine increased the risk in 30% for severe perineal trauma. And it indeed decreased the risk of perineal anterior trauma, but these are less severe. And for fetal conditions or neonatal conditions, there was no difference. Then, in women where no instrumental delivery is intended, selective episiotomy policies resulted in fewer women with severe perineal trauma. And thus, the review demonstrates clearly that believing routine episiotomy reduces perineal or vaginal trauma is not justified by current evidence. It's not really justified as a routine. But the problem is that our hands often don't obey. Some people know it. Some people are reading the evidence. People participate in Congress, and this is said everywhere. This is said everywhere. But even though many people don't believe or don't obey, as if they had scissors as hands, or as if they had hands as scissors, and they cut by, I don't know why they cut, because they are used to do this, to do that, and because sometimes they have beliefs that are very entrenched in their minds. Well, but there are yet some doubts. If a routine episiotomy is not recommended, when should it be recommended? We don't really know. Some people believe routine or episiotomy should be made if we have an operative vaginal delivery. And we have, excuse me. And there are many discussions about that. A pilot study made in 2008 that included 200 women did provide conclusive evidence that a policy of routine episiotomy was better or worse than a restrictive policy, even for women that had an operative vaginal delivery. But a more recent publication, it was a review that included national registries in Nordic countries, England, Danish, Dutch and Finnish medical birth registry. They found in these national registries a substantial reduction in the risk of OAGs, is obstetric anal sphincter trauma. They found that this kind of trauma in the anal sphincter was decreased with episiotomy when an operative vaginal birth was made. And the conclusion is that in the absence of conclusions derived from randomized trials based on national registries, they concluded that the episiotomy should be made when an operative vaginal delivery is needed. But we have to agree that this is a very this is not a strong evidence. This is a very weak evidence indeed, and this does not means, or this does not mean that this is really true. This is sometimes the opinion of the author of this review. Well, then it's very clear we have to be very certain that episiotomy is not a technique to protect perineum from trauma. If you have to protect perineum from trauma, we have to see another techniques, and we will see it. We have at least three. The first one is antenatal perineal massage for reducing perineal trauma. And this was studied, and how or when or who should do it. Perineal massage requires approximately 10 minutes daily. It should be done daily, starting at 34 to 35 weeks gestation. It's very simple. The woman or her husband can introduce 1 or 2 fingers, 3 to 4 centimeters deep into the vagina, apply and maintain pressure, first downward for 2 minutes, and then for 2 minutes to each side of vaginal entrance. Kind of some oil, sweet almond oil should be used for lubrication, but other kind of oils also should be used. Was used in this trial. And how are the outcomes? Cochrane identified 4 studies with more than 2,000 women, all of them of good quality. And the conclusion was that only for women without previous vaginal birth only, no difference in the incidence of 1st and 2nd degrees perineal tears or 3rd and 4th degree perineal trauma, but it reduced the likelihood of perineal trauma, mainly including episiotomies, and the reporting of ongoing perineal pain, and is generally well accepted by women. Well, there was no difference for severe perineal traumas, but if we have a decrease in postpartum perineal pain, this is already a very good thing. Then this is recommended even in the antenatal care, beginning from 34 weeks. Intrapartum perineal massage, this was studied too, and we have at least 2 recent systematic reviews, Cochrane and Aquino. The Cochrane review concluded that the incidence of intact perineum was increased in the massage group. In the control group, there was an incidence of 2.5% of perineal trauma, of 3rd and 4th degree perineal trauma, compared to only 1.3 in the massage group. The other review included 9 studies, and the conclusions were basically the same. Perineal massage performed by the midwife during the 2nd period, between and during the pushing efforts, with the index fingers and the middle finger using a water-soluble lubricant, and perineal massage was associated with a significantly lower risk of severe perineal trauma. But how were these intrapartum massages performed? Well, the 2 largest studies included in this review were the following, and they described the kind of perineal massage they did indeed. Well, how they did this kind of massage? Because this is a very sensible topic for the woman, because it implies to put the fingers and the hands over the perineum of the woman. Then some people don't like it. But how did they that? Perineal massage with lubricant was gentle, slow massage, with 2 fingers of the midwife's gloved hand moving from side to side just inside patient's vagina. It was mild, downward pressure toward the rectum was applied with steady lateral strokes, which lasted 1 second in each direction. And this motion precluded rapid strokes or sustained pressure. There was a lubricant, and massage was continued during and between pushes regardless of maternal position, and the amount of downward pressure was dictated by the woman's response. Then we have to ask for the woman if she agrees or if she really wants or if she allows it. We cannot do that without allowance of the woman. Well, and the third one is warm compress. Warm compresses were clean, washed clothes, made warm by measure in tap water and squeezed to release excess water. They were held continuously to the mother's perineum and external genitalia by the midwife's gloved hand during and between pushes, regardless of maternal position. And they were changed as needed to maintain warmth and cleanness. Which were the conclusions or the outcomes? Moderate quality evidence suggests that warm compresses and massage may reduce third and fourth degree tears, but the impact of these techniques on other outcomes was unclear or inconsistent. And we can see here third or fourth degree perineal tears. Yes, indeed, the risk was reduced in a significantly way. And finally, we have to decide if we have really to put our hands on the perineum of the woman or if we should not put our hands. There are many maneuvers that were described to protect perineum with our hands. One of the most famous of them is the Röntgen's maneuver. It was described more than 1 century ago. And how it is done? It is done through, as long as the fetal chin is reached, as long as it reaches posterior perineum, between the anus and the coccyx, and then the hand of the carer or the midwife or the doctor pull it anteriorly while using the fingers of the other hand on the fetal occiput to control speed of delivery and keep flexion of the fetal neck. You can see in the figure, I think it's clear, how is this maneuver done. But is it really effective? It can really protect perineum from severe tears. Should we put our hands in the perineum during second stage of labor? This is the question. This publication or this paper, in this paper, they studied the Röntgen maneuver, and they studied it in more than 1,000 people, 1,000 women, and it was performed during a uterine contraction rather than as originally recommended between contraction. But the conclusion was that it was not really effective. It was not really effective to protect perineum from severe trauma. Then it is not useful. This was the conclusion. 3 systematic reviews evaluated the practice of hands-on or to put our hands on the perineum compared to hands-off practice or just to see and to see childbirth and not putting our hands on the perineum. And these are the 3 reviews. First one 2015, 2017, and the most up to date in 2021. This is the newest one of them. The first one concluded that was no significant reduction in perineal support maneuvers in the risk of OAGs. OAGs, again, is the severe perineal trauma. The perineal trauma that affects anal sphincter. Then no difference in the Cochrane review found the same thing. The practice of hands-on compared to hands-off practice showed no difference for important outcomes, including third and fourth degree tier. No difference. And finally, the most up-to-date one, here's Sweden's review, the same conclusion. And all of these reviews did not show a beneficial effect of the hands-on over hands-off techniques in regard to perineal trauma. Then the conclusion is that we still don't know for sure how best to prevent perineal trauma. But apparently it's much more than putting our hands in perineal or any kind of perineal protective maneuvers. Of course, warm compresses, antenatal and intrapartum massages, all of them can be useful some way. But the two largest studies included in the meta-analysis evaluated an intervention program that included not only manual perineal protection maneuvers, but also other aspects of childbirth, such as a good communication between midwife and woman, position at birth that allows visualization of the perineum during the last minutes before delivery. And in these two non-randomized studies, they included episiotomy in selected cases. But the problem of episiotomy ever, when we talk about selected cases, is that we don't know which should be the selected cases. Well, and here we have the policies for perineal protection, the policies from WHO recommendations, techniques for preventing perineal trauma for women in the second stage of labor, techniques to reduce trauma and facilitate spontaneous birth, including perineal massage, warm compresses, and a hands-on warding of the perineum are recommended based on women's preferences and available options. Well, hands-on, it was included in the WHO recommendations, but I've just shown you the evidence about that. And about the episiotomy policy, routine or liberal use of episiotomy is not recommended for women undergoing spontaneous vaginal birth. And this is a thing that is already known, we can say, for at least 20 to 30 years. Because since 1983, we already have been studying, and it is already demonstrated that it's more dangerous than beneficial for perineum of the woman. And I will finish my lecture with this beautiful picture. I like it very much. It happened in our hospital, and we can see here the emotion, the feelings of the husband and the woman, and we can see that the position was, I think she was sitting in a seat, and she was under the shower, and she was bathing. We can see that hairs are some way washed. And here we can see this, the husband participating, cutting the cord, and the baby is in skin-to-skin contact with her mother. I think this is a very beautiful, I like it very much. Well, this was I had for today.
Thank you so much, Dr. Edson, for a very informative session, and it was lovely to hear from obstetrician, some senior consultant obstetrician from you, this all real and fact about physiologic birth. Am I audible, dear guys? Yeah, okay, thank you so much. I guess all of the audience are getting so much excited to see such a fantastic topics. So we have Anabran from Belize. We have Mavihe from Tehran, Iran. We have yes, Maral from Iran. We have Juliet from Dubai, and she's a registered midwife from Dubai. And we have Diane Lockhart, our training committee from Kampala. We have Nivedita from Qatar, and Gail from Brazil, Zahra from Iran. So very fantastic to see all of the world in one screen, and we are so happy that we can make a team from midwives and OB/GYN doctors to reach physiologic birth words to all of the world. So dear guys, if you have any question, now we are entering into the second technical session of today in this topic. If you have any question, please you can write in chat box, or please turn on your camera and unmute and ask your question. Dear all participants, we will provide certificate to all of you, but we ask you please turn on your camera. Otherwise, we are not able to identify and provide your certificate. Yeah, Maral from Iran, thank you. Thank you so much. Thank you, Dr. Edson, for your valuable insight in this topic. It was fantastic to hear about episiotomy, about perineal care, and yeah, please write in chat box from where you are joining us, please. Zulfa, Crystal, Parveen, Juliet, Nivedita, Malihe, Eli, Ermawati, Zahra, Razia, Dayan, Maral, Farah, Mariam, Zahra, Asafe, Anna Braun. Welcome all of you, and please write in chat box from which part of the world you are joining us. We have the other free training course, dear guys. You can join us, and we are going to celebrate International Day of Women's Health on 8th March with very fantastic session. We have a yoga session from experts in Yoga Institute from India. We will have some Indian dance from our celebrities, and we are going to have some talk show with specialists and experts in panel about sexual reproductive health and rights. Oh yeah, thank you. We have Farah Casey from Saudi Arabia, Zahra from Iran. Yes, thank you so much. Thank you for turn on your camera. We have Zulfa Homeira from Brunei. Thank you so much, Mariam. Return thanks again for your experience with me today. Okay, please, if you have any questions. Yes, Gail, you are on mute. Go on, please.
I didn't want to interrupt. First of all, once again, the presentation is awesome. It stimulates thinking and it stimulates discussion. And those are the ways I learn. Is, you know, I appreciate all the research because it shows that there are better ways to do things than we are still teaching in medical schools and still teaching midwives. I'd like to talk a little bit about the pushing first. The best thing about pushing is what I should say what I attempt to use is simply, I call it breathing the baby down. In other words, the woman, if she has no feeling to push, then she doesn't need to push. When she has a contraction, she simply breathes exactly as she does while she's in dilation. So she lets the body move the baby down gently. This saves her a lot of energy. It stops the purple pushing. So until she feels this spontaneous, absolutely, I have to push by herself, I do not encourage her to push. One of the other things that was pointed out is that when you have an epidural, you lose the feeling of your lower body. You lose the ability to know if the baby is ready for a spontaneous push or not. And so it recommended, according to the study, that you wait until some of the epidural has worn off so the woman can then participate in being more spontaneous. However, that doesn't always work well in hospitals. The drug doesn't wear off, and so the woman can't participate as much. The other thing, if you use directed pushing, you are going to cause the baby to have more trauma to the head, because when you breathe the baby down, the head can mold more gently. Yes, it may take longer, but the heart tones are usually better. One of the reasons I have found for doctors and midwives to be very concerned is during pushing, the fetal heart tones go down, which is normal. But when you use the directed pushing and the mother is holding her breath and pushing for a very long time, like 10 seconds or 12 seconds, you're causing the baby to have a lower pulse. It's sort of like what I try to explain to my mothers is the head coming down should be 2 forward, 1 back, 2 forward, 1 back. If you just constantly put pressure, 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 push, push, push on that head, the fetal heart tones are going to go down much more. So it's 2 forward, 1 back, 2 forward, 1 back. And that way the baby gently comes down, molding gently takes place until the baby gets to that spot where the woman says, I have to push. And then, just as Dr. Edson pointed out, then she will only push for 2 or 3 seconds. She will kind of to get the baby out. She won't force it out, which also then reduces episiotomies. Because again, the tissue can be allowed to stretch gently. I have found women do not like to do the massage in pregnancy. They don't like the men to do it. They don't like to do it themselves. There was a study in the year 2000 by the midwifery community, and we found that those that did massage had more tears than those that didn't do massage. So I'm not exactly sure why, but immediately all the midwives that I know stopped encouraging the mother from doing a massage. They didn't like it anyway. I do think that oil being squirted in there with like olive oil being squirted into the vaginal opening will help the baby maybe be a little slippery. At least it's a psychological thing for the mothers to think so. And a mother will stop pushing when she feels that ring of fire. And you will find she instinctively puts her hands down there to protect the spot that she feels a lot of pressure on, or a lot of a feeling of too much stretch or a possible tear. So that's about what I have to say. But the other thing that I noticed is that epidurals are causing more tears. So yeah, so it's another reason for a woman to try to find ways using self-hypnosis or calming or having a warm compress down there to make herself feel more comfortable and more in control. So those are some of the things that were going through my head when I was hearing about all the research. The other thing every woman knows, if you have a piece of cloth, if you have the baby's coming down and the head is pushing here like this, the baby is pushing here like that, what may tear is a first-degree tear, but then you're only tearing skin and mucosa. You're not tearing the muscle back here. A woman also knows if she sews that if you can pull on material and it will stretch to a certain degree, depending on the material. If you make a little cut in that material, it will rip very easily. And that's the damage of an episiotomy. Once you have material, then it will rip more. And you can get your 3rd and 4th degree tears. Midwives at home, most of the time we get 1st degree tears. We don't get a lot of tears for that go further because we don't do episiotomies. So on that note, I'll let you ask questions, but the presentation once again is awesome because it stimulates thinking. And that's what we're all trying to learn, is a better way to do something. And I do not have the research statistics that Dr. Edson does, but I just have years and years of experience and watching and learning and listening. And I did learn from some wise doctors like you, Dr. Edson. I learned so much about turning breech babies. And yes, so that's all I have to say.
Thank you, Gail. Yes, I think the best practice we have to consider the evidence, naturally, but the experience of provider, and of course, what women are thinking about. We have to consider at least these 3 points. They are very important. Evidence, women's feelings, sensations, and what they desire, and experience of provider are very important. And the experience of the midwives are, I believe, the must of them, because midwives are the people who really care for the woman during labor. And then, yes. Well, I agree. I'm always bring evidence in order we can discuss, in order we can hear what other people are thinking about, because this is the way we can move ahead. I would like to hear from you. I have seen that are people from many countries here. It should be very good if we can hear from you what we have been doing, what we think about this kind of evidence, the obstacles you have in your places, in your hospitals, because the only way to move ahead is to discuss and to gather strength and to go ahead.
Everybody share your experience with us. We have Juliet from Dubai. We have Anna Brown from Belize. We have, can you please write from which country you are joining us anyhow? Zulfa from Brunei. We have Farah from Saudi Arabia. We have Maral from Iran, Maliha, Iran, and pardon? We have from London, Parveen from Tehran, from Iran. We have from Lebanon. We have from Qatar. We have from Dubai, Kampala. Please share. I want to ask you, if you don't turn on your camera, I will ask you to turn on and ask you questions, share your experience, please. Okay. Zasan, Basil. Zasan, can you turn on your camera and share with us from where you are joining? Who else wants to share experience? And Farah from Saudi Arabia. Farah, Diane, Nivedita, Malihe, Eli Ermawati. Who wants to have a short word with us? Farah, you want to share something? Shall I give you access, please?
Yes,
Okay, please.
I
Come
would
on,
like
Farah.
to.
Farah,
I would like
yeah,
to
please.
ask to ask something
Or
or
Juliet
two.
from Dubai. Zasan Basil from Nigeria. Yeah, who wants to? Yeah, Farah, I give access to you. Juliet, you want to share? Diane, what about you? Juliet, it's written that there is problem. I cannot turn on my camera. Okay, it's okay, no problem. I'm Thicken, Anna Thicken, okay? Anna Brown, Atife, Zahra, Razia, who wants to talk? Diane is written, sorry, I can't share. I'm in my labor room with a mother who has had an IUFD, which is why I can't talk. It's okay, Diane. Thank you so much. You are our brave midwife and we understand you. Ahlan wa sahlan.
I would like to ask,
Yes, please.
I would like to ask a question of Dr. Edson. How can we possibly get doctors and midwives that work in hospitals to stop doing episiotomies? I send them research. I talk to them, but they all seem to like, there's so many episiotomies, like 70% here in Belize, 90% get an episiotomy. And I keep sending the research that I can get my hands on, and things are not, I've been doing it for 15 years and things are not changing.
Yes, how can they stop doing episiotomies? We have been doing this kind of question here too in Brazil. Hospitals in Brazil, not so high. Things changed some way in the last 10 years, but we still have some around 30% in many hospitals, but not so high. In our hospital, we have our rates are low. We have around 2-3%, too low, and this decreased a lot for the last 20 years. But 10
Wow.
years ago, we still had something around 10%. In 10 years, it decreased to 2%. It's too low. I believe people here still do it when they have operative vaginal birth. But yes, your question is a very good question. How to stop doing episiotomy? Because people, I have talked to many academics, to doctors that teach in the universities, and they know the evidence, they know the literature, but they can't stop doing that. As if
Why?
they had scissors. Yes, as if they had scissors in their hands. And I've heard that from a very young doctor some years ago, because she said to me, I'm already trying, but I can't refrain from doing that. I think this is a kind of thing that is inside her. No, this is not something that's inside their minds. It's in their hands. It's something reflex. It's in their hands. One time, I was thinking 10 years ago, I was still learning something 10 years ago. I was seeing that I was caring for a woman, and the head of the baby moved ahead and back, ahead and back. And 1 minute passed, 2 minutes, 3 minutes, 10 minutes, 15 minutes, and I had a scissor in my hand. And there was a student near to me. and I was feeling that he was here. I'm sure her heart rate was very high. I felt it from her eyes, and myself too. My heart rate was because time was passing, 15 minutes, 20 minutes, and the head in that situation. But at the final, I will finish my history. Yes, I got to refrain myself, but I was doing that, and I was thinking what should be passing in the heads of my colleagues too, because we have to be very sure. And there was a midwife by my side. There was a midwife by my side. I think I should feel myself a little ashamed if I had cut that perineum, because the midwife had her eyes set on me. I don't know if this will if it will be the same effect to other people, but this happened. But I think people have to know physiology, and this is the kind of thing sometimes is not possible in the teaching hospitals. They don't allow the physiology to happen. And I don't know how to do that. In our hospital, we have midwives as if they can guarantee that things will go this way. But we have to reflect, Gail, have to reflect how to do that. You have been sending literature, publications, and the studies, and people don't move.
Nope, they don't move. It's one of the ways I think we can do it in America is when we teach our pregnant mothers. Again, we're back to childbirth classes, how much importance education is about delayed cord clotting and no episiotomies. The mother can tell the doctor in America, if you cut me, I will sue you. So that works in America. Sue, like they're going to take them to court for medical abuse. But that doesn't build a good relationship with your doctor if when you're pushing your baby out, you're saying those words to him. So that's not a good suggestion. I'm just saying that one of the ways women are finding out to protect themselves is they get in the birth, have water births. Because if they're in the water, the doctor can't get to the bottom with the scissors.
Yes, I think the woman protecting themselves it's a good way. In Brazil, there are some movements from women. They have as a flag, as if they had a flag. We don't want our perineum cut. We don't want episiotomy, because I think this will be the only way. Because if we let the decision, if we let,
again, we're back to educating the consumer, right?
Yeah, because if we let the decision and the literature, when we say it's not routine, we let the decision to sometimes to the desire or to the assessment, to the subjective judgment of the doctors. And I think the woman protecting themselves is the only way. Because
water birth helps a lot.
Well,
water births, getting in the water. The doctor can't get there with scissors.
Yes. It's a good idea.
Well,
Inside, yes.
And then the warmth also helps keep her perineum relaxed. So it helps it stretch a little bit more. And the other thing I want to share with you, it's kind of funny. We have if our mouth is open, our vagina will be relaxed. So if a woman is pushing with her mouth open, like gently, like ah, 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 but if she's like this, the vagina goes too. So she's and we can feel that. We must be relaxed. Our mouth and our vagina are really together. So we breathe our babies out like ah, 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 instead of then the bottom goes like that too.
Good.
So, and sometimes I've had ladies, we get more tears. That somebody said the research showed more tears when the woman was up. That's because she's blasting the baby out. The doctor or the midwife is saying, push, push, push. And now she's got gravity on her side. She's got the weight of the baby on her side. Now she pushes like that and she just explodes the baby out. When you explode the perineum, it's going to tear.
Yeah.
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 So we've got ways to
Some
let
comment-
out
Sorry,
slowly.
sorry, I disrupt you. We have one comment from Diane, if you don't mind. I share. She's written, episiotomy is still routinely done here, especially with PGs. Even before head is on the perineum properly. And we have some comment from Zulfa Homeira. She's written, in Brunei, we are still practicing episiotomy, especially for first-timer mother. But most of the time, we will do the episiotomy based on our judgment. I prefer to let the perineum to stretch in Brunei also. Zulfa, yeah, thank you so much, Zulfa and Diane, for sharing your experience. If you want to, anybody else wants to share experience? If you want, I can give access. I think I'm not able to unmute any of you. An Atife, Mariam, Diane, Zahra, Malihe, Nivedita, Juliet, Maral, Eli, Zahra, Razia, Zulfa, Zasan, Parveen, Behawani. Anybody who wants to share? I think I'm not able to unmute. Can you please check if it is possible? Pardon? Behawani, do you want to share some? Okay. Zahra, Eli, Emrawati. Anybody from Dubai, from Saudi Arabia, Qatar, from Asian countries? We have from Indonesia and from Indonesia, if you want to share. And if you want to share something, I give access to, if you are, yeah. Okay, please. Parveen, I guess Parveen Zagaran is one of our training committee from Middle East. And previously, Parveen was asking how we can have some evidence practice regarding reduced episiotomy to discuss with OB/GYN doctors there. So I guess this session was very, very informative, and it was very valuable insight for all of midwives and doctors who don't believe on episiotomy. Really, we had the gap of this evidence that today it was so helpful for all of us. Here, all we will share your certificate in 24 hours. But as I explained before, if you don't turn on your camera, our IT team cannot verify you. So we will not count as an active and dynamic participant. Then we cannot provide certificate to you. Please, if you want to get certificate, turn on your camera. Thank you so much. Juliet is written, our doctors still want to do the episiotomy because for them, it's easy to repair the episiotomy than to repair laceration. Such a nice point, Juliet. Thank you so much. Yes, Yes, exactly. This is what doctors believe. They says laceration tears is not easy to manage and for suturing. And yeah, it is most of obstetrician and gynecologists believes. Thank you so much, Juliet, for your nice points. Okay, who else? Zahra, thank you so much. دوستان عزیز اگر ویدیوتون روشن نباشه ما به شما نمیتونیم مدرک بدیم گواهی. Dear all, please turn on your cameras. Thank you so much. If you want to have certificate, please turn on your camera. Thank you so much. Okay. If you have any other comment and suggestion, please let us know. Yeah, thank you. Okay. Do you want to add some words, Doctor or Gail? Doctor, what's your suggestion about this point that came by Juliet about laceration is difficult to repair than episiotomy? How we can answer to our doctors partners in this regard? Doctor, I can't hear you. Dr. Edson?
Gail,
Yeah.
I would
Yes.
ask you one thing. What do you think about shouting during labor? Because some women shout in labor, really.
Yes.
And I've already heard from midwives that when a woman is shouting, it is because she was not prepared for birth. I don't know if I should agree with her, because I've at least in our culture, sometimes to shout loudly, this is viewed as a sign of power. And indeed, when we climb a mountain, for example, we like to shout, to demonstrate that we are in harmony with the nature, and we are part of nature, and we can shout because this is a demonstration of power. And one of the things most important.
I think the difference is if it's high pitched yelling like
Yeah.
that's scared. If it's if it's deep, and even when they're in labor, if the sounds are like that's better than high pitched is fear and tension, but loud, deep sounds are good. They're from the gut and from the heart. Yes, I agree with you.
Good. Thank you, Gail. Yes,
Doctor,
they may be free to vocalize, to this is part. We cannot forbid or to stop their manifestations. Thank you, Gail.
Yeah, some people are very vocal in sex too, but if it's high pitched, it's fear. If it's low pitched, it's enjoyable.
Good.
Diane, am I audible? Yeah.
Yes, and there is a commentary here.
I'm going to read from Diane. Yes,
Good.
doctor. From Diane is written, in Uganda, we have many tribes and each tribe makes different level of noise. Most are very quiet and not being allowed to shout as it is a sign of weakened. But as Gil says, when they scream uncontrollably, that is fear and doesn't help with pushing. So I find I have to refocus their breathing with them. And Zulfa Homeira, it's written, we are still encouraging women to do Volsova Maneuver. In our culture, the women are discouraged to shout during pushing. Lovely point. Thank you so much. And Zasan Basil is written, doctors and midwife believe that once the head of the baby is not compatible with the vagina, they do it to increase the size of vagina to enable the head pass through. Thank you so much. Very nice point. Thank you.
It's amazing to me.
Really?
It's amazing to me that animals can do it with no education. They follow their instincts. No one cuts their cords for their babies. No one massages their perineums. No one stops them from a cow from going moo. She moos. It's amazing that if we can allow nature to and convince the woman that her body instinctively knows how to give birth, it's an entirely different perspective when we admit that we're animals, and yet we pick up fear. What do we get in pregnancy? We get fear education. We have a high episiotomy rate in many countries because they don't want, some people think that the baby is going to stretch the vagina and that the intercourse will not be any good anymore. None of that's true. None of that's true. But we get these ideas in our head, which animals never get. And so birth for them is more peaceful. No animal gets their bottom cut to get a baby out. So why are we saying that God, the universal creator, Allah, didn't know how to make women? It's amazing to me that if we let women follow their bodies and don't put them in positions that are not good for them, if we give them love and a safe place to birth and quiet and darkness, and they want to be, animals go away from people. They go away to birth their children. They hide from us. We need to pay attention to that part of birth, the part of where a woman all she needs is quiet, love, and care, and where she feels comfortable enough to be and to do what she needs to do to aid her baby to come out gently, slowly, and well. And we don't have that in hospitals. As much as I think there's loving people there, just the atmosphere, the smells, the normal people coming in and out to clean the floor or change some paper in a machine or adjust the belt. All of these, if you did any of these to an animal, their labor stops. That's why there's so much augmentation. That's why there's so much Pitocin used. That's why women need an epidural, because they are not being allowed to get into themselves. It's very much related like a sexual experience. You cannot have a good sexual experience if we were doing to the family or the couple or the wife or the man any of the things we do to our women in labor. We need to stop. We need to stop and just give them a safe place with someone in attending who is willing to sit on these eager hands that we have. We have eager hands to do something. We all know that. I do as well. I'm as guilty as anybody else, but we can't interfere in the relationship between a woman and her child because we think we are trying to be helpful, and we are, but sometimes it's not helpful. That's all I can say.
I would like to talk something about the last message. Sazam Basil said that doctors and midwives believe once the head of the baby is not compatible with the vagina. This is a very strange assumption that the head of the baby should not be compatible with the vagina. This is not, this is a kind of belief we have. This is the result of the formation we have. It's only a belief. It's not really true. We don't have to modify or to change the vagina. We have to change the way we see the vagina. The vagina was the result of millions of years of evolution. And then this is not true. This belief is the result of the way we have been seeing the vagina during the last century only. We have to compare 1 century of beliefs with millions of years. Then I think the first thing is to know clearly, this belief is not true. This is a false belief. And as a false belief, we have to defy it. We cannot accept it as a true, as a truth. Okay. It's a, yes, I agree with Gail. It's very strange because we have been talking about that for more than 30 years, 40 years maybe. And we don't believe it's already proved that this kind of belief is not true. But we have to do it many times.
Very good point you mentioned. We have other problem in some Asian countries that women, they think if they go through vaginal delivery or if they go for a normal tear, they will have loose vagina. And they're concerned about their vagina feature. Yeah, figure. It is one of the most important issue that's happening in Asian countries. That's why they want their vagina to be tight and go through for cesarean section. It is the real what we were engaging with that. And there is one more comment from Zolfa Humeira. It's written, I think most of the midwife in our place do agree with the points mentioned by Gail Johnson. However, to the maternity care system and hierarchy culture within the system, it made us the midwife harder to promote physiological process of labor.
Totally agree.
What Zulfa said is very important. And we have to be we have to use all of our skills, intelligence to move the things ahead. Because sometimes we can, I will tell you a history that will, I think this will be meaningful to you. One time I went to a hospital and I gave this lecture and I said that we should not do episiotomy as a routine. And that night, there was a woman in labor. That was a laboring woman. And the young doctor that was caring for this young labor did not the episiotomy. And imagine you what happened that night. That woman had or suffered a 4th-degree tear. Terrible thing.
Terrible thing.
Terrible thing. And I understood that sometimes it is very dangerous to do the right thing, because that young doctor was viewed as the worst professional of the hospital. And I think I could not go to that hospital again, because I felt that people judged me as if I had given the wrong recommendation. and their beliefs became even stronger. Even stronger. But I realized what I have did, what was my mistake, because I've made a mistake that day. Because we know that we have not to do a routine episiotomy, because this will not protect perineum. But that young doctor heard me. He understood that should not do an episiotomy, but he had not yet learned the whole thing about childbirth.
Right. That's
And
that's
then,
it, because he was probably still telling her to hold her breath and push, 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 push.
yes,
And
yes.
yes. So it has to be the whole picture of gentle, loving care. Yes, I totally agree. That's a good point. Good point.
Yes, because we have to be very careful, because when we advance, we can make the beliefs stronger. If something happens like this, then the beliefs in that hospital about episiotomy became even stronger. They believe even their beliefs seemed totally right, and science and evidence totally wrong. And the midwives that were trying to move or to change something, as they were totally mad, and they were even more marginalized. And this is because we have to go very carefully. This
Yes.
I've learned this that day. I've learned it was a terrible lesson to me, because I felt myself guilty too. And I can imagine the feeling of that young daughter there.
Yes. Yes. He was probably devastated. And as you say,
Devastated.
I totally can understand it. But yes, we have to educate the women, and we also have to teach the whole picture. We have to teach the whole picture of the woman following her instincts. I understand, because she blasted the baby out. It exploded. She just exploded the baby out, and you cannot do that. We don't, when we're trying to learn to touch our toes, we do it a little bit more every day. We don't ruin our back and rip our tendons out by having someone shove our legs above our, everything that we do with our body has to be done gently. Improvement, exercise. You cannot go from doing nothing to being the yoga master overnight. You will kill yourself.
Yeah. Okay.
Yeah.
Yes.
Request everyone to share the email ID and full name that we can send the participant certificate. Please send the details and info@lilymcenter.com or WhatsApp at 009811642221, mentioning the complete name and session date in the subject line. Thank you so much. We have other free training, and we have 8th of March, International Day of Women Health. We will be happy to hear from you all guys to celebrate this important day and sit together from different parts of the group. We will have one basic yoga session in International Day of Women Health. International Day of Women. So regarding our previous yoga session, you were requesting to have a small basic yoga. So we designed this celebration with Yoga Institute from India to provide you 30 minutes basic yoga for empowering women and midwives. We will have celebrities and female artists from different parts of the world in this day, and we are going to have one talk show regarding sexual reproductive health and rights. We will have expert panelists in this session, and we will have a very, very fantastic talk show regarding single mother issue and sexual harassment in India and different other countries. So if you have any idea and suggestion for celebrating International Women's Day on 8th March at 8 p.m., please don't hesitate to share with us. If you have any more questions, please write in the chat box. Thank you so much. Thank you. Thank you. You're writing your email address. Okay. Yes. Yes. Thank you so much. I guess we answered all of the question and all of the doubt. And if you have any more doubt or question, we had very fantastic session, informative session. Thank you so much, Dr. Edson. Thank you, Gil, for your so impressive experience. I think we are good now, and thank you, everyone. It was a pleasure being with you up today. Please, if you don't mind, turn on your cameras. Dr. Edson, if you have any words for end of the session, please. And
Well,
please turn on your cameras, please. Yes, Doctor.
Yes, I would like to thank you once again, and to thank everybody for the participation, for the opportunity to know you and to exchange information and knowledge. And yes, a goodbye for you all, for everything, and a big hug on you all, everybody.
Thank you very much.
Thank you.
Thank you, everyone. We appreciate you being here. Thanks again for joining us today, and we will see you again in 8 March, 8 p.m. IST, India Standard Time. Thank you, Dr. Edson. Thank you, Gail.
Thank you.
Thank you, Zahra, Parveen, Zahra, Mara, Juliet, Eli, Razia, Sazna, Bahavna, Suwa, Mariam, Maral, Atife, Anna Brown. Thank you. Have a nice day and take care. Bye. See you guys and love you. Keep in touch. Thank you.